So let's now move on to the real-world evidence for the basal insulins. We've seen some of these data presented. This is for the growing evidence base for glargine 300. On the left-hand side in the blue, you see the randomized controlled trials. And Alice mentioned some of these, the addition studies and the meta-analysis of the addition studies and the senior study. Then the BRIGHT study. And then on the right-hand side, we see the plethora of data being generated in the real-world setting for glargine 300. And at the top, you see the number of registers in the databases that are being used to generate this evidence. In terms of the glargine 300, randomized controlled trials, about over 7,000 patients have been included in these randomized controlled trials, registration trials and phase 3 trials, and these include the ones I mentioned, the addition, BRIGHT, senior and junior trials. However, when we look at the real-world evidence that's been generated for glargine 300, this includes over 200,000 patients from various databases with various comparators. That tells you the power of real-world data and looking at various aspects in real-world clinical practice. In the deliver naive, as you can see, the baseline HbA1cs were higher, and Pratik showed that when we initiate insulins in the real-world setting, HbA1cs are around 10%, but the reductions we get are similar in the real-world setting. Maybe people ask, why are they not lower? Because we're starting at a baseline, but there are issues regarding adherence in the real-world setting as well. If we look at the differences between insulin glargine 300 and insulin degludec, again, no difference in terms of the reductions in HbA1c between the two insulins. Now, if we compare the hypoglycemia rates, the BRIGHT study, anytime hypoglycemia, this is a proportion of people having hypoglycemia. As you can see, there was no difference between insulin glargine and insulin glargine 300 and insulin degludec. This is events per person per year. Again, no difference for confirmed 70 milligrams per deciliter or confirmed 54 milligrams per deciliter between glargine 300 and insulin degludec. If we look at the deliver naive study, again, similar findings. All hypoglycemia and the more severe inpatient or emergency department hypoglycemia, no difference between the proportion having hypoglycemia between insulin glargine 300 and insulin degludec. The events per person per year, again, no difference for all hypoglycemia and inpatient and emergency department hypoglycemia. There are no differences in terms of the forest plots. However, there are differences in terms of the event rates. This is the proportion much lower than in the BRIGHT study, and the proportion event rates per person year much lower compared to the BRIGHT study. And the reason is, in the BRIGHT study, people are asked about hypoglycemia on a regular basis. They're keeping diaries. However, in the real-world setting, we do not capture all the hypoglycemia rates. And there are a number of data showing that we do not capture the mild hypoglycemia rates. Many patients don't even go to the emergency department at all. And that's why we always see lower rates in real-world setting compared to randomized controlled trials. This is the deliver high-risk study. These were people who are high risk of hypoglycemia. Either they had renal impairment, they had previous hypoglycemia, atherosclerotic cardiovascular disease, older patients, or they were on sulfonylureas. And these were people who either went into insulin glargine or first-generation basal insulins. So this is insulin glargine 300, and these are the people who were switched to basal insulin first generation. And what we see, the reduction in HbA1c, 0.5%, very similar between the two groups. In terms of any hypoglycemia, no difference in the switches onto insulin glargine 300 or going on to the first generation basal insulin, but a significant 27% relative risk reduction for the severe end of hypoglycemia, favoring insulin glargine 300 in this high-risk population. So in summary, I hope I've shown you that many people who we see in the routine clinical practice are excluded from randomized controlled trials. And there is a comprehensive program for all therapies, including glargine 300 that I've mentioned today, from trials to real-world evidence. And what we're seeing here is that the results from randomized controlled trials and the real-world evidence are consistent to what we have seen in clinical practice and randomized controlled trials. And the subgroup analysis suggests that the second generation basal insulin analogs may offer similar benefits in high-risk populations who are excluded from randomized control trials. And finally, I'd really like to summarize from the data that we've seen is what Dr. Julio Rosenstock summarized for the BRIGHT study, that there are more similarities than differences between these two second-generation basal insulins. Thank you very much for listening.